Right. Good afternoon, everyone, and welcome to this month's Teach Educational Rounds. Today we have a special Roberta Ferrence lecture series, and it will be on brain stimulation and smoking cessation, interventional neuromodulation approaches for nicotine dependence. And we have Dr. Victor Tang, who will be joining us today to speak on that. So welcome, Victor. And I'll start off with CAMH's land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. And today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805, with the Mississaugas of the Credit. And Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation, and we will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our current practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So I've noticed some people already saying hello, but we welcome anyone to share in the chat where you're joining from and something that you're currently doing to learn or improve your commitment to reconciliation. And in the meantime, I'll share a bit of my own land acknowledgement. My name is Rachel. I am a second-generation Canadian located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty 13. And I continue to listen and learn about stories and cultures of various Indigenous communities and ensure that their voices are heard. So everyone's welcome to continue sharing. We're going to keep going, but please feel free to introduce yourself and share where you're coming from today. And this is just a reminder that if you were interested in receiving a letter of completion for this Roberta Ferrence lecture, to make sure that you registered for this webinar and completed the pre-learning assessment, as well that you please sign into this webinar using your full name, your first and last name, so we can identify you, and then also to complete the evaluation and post-learning assessment, both of which will be sent out to you at the end of the webinar. And now we have Sarwar Hussain, who is our director at Intrepid Lab, and he's going to share a little bit more about the Roberta Ferrence lecture and Roberta Ferrence herself.
Great, thank you, Rachel, and good afternoon, everyone. As Rachel mentioned, today's lecture is part of the Roberta Ferrence lecture series, and it is named in honor of Dr. Roberta Ferrence, who has made a lifetime of contributions to the tobacco control space, not just here in Canada, but also internationally. Among her many accomplishments, Dr. Ferrence was a professor at the University of Toronto Dalla Lana School of Public Health and a senior scientist here at CAMH. He was also the executive director of the Ontario Tobacco Research Unit, or OTRU, during his formative years from the year 1993 to 2011. And for many of us who are in the tobacco control space today, we owe much gratitude and our inspiration to Dr. Ferrence, who has been a mentor to us both formally and informally throughout our career. So thank you, Dr. Roberta Ferrence, for all the contributions that you have done to the space and elevated Canada's position in tobacco control internationally. I am honored and excited to invite Dr. Victor Tang to our discussion today. Dr. Tang is a scientist at the Institute of Mental Health Policy Research, and a psychiatrist within the Addictions Division at the Center for Addiction and Mental Health. He is also an assistant professor in the Department of Psychiatry at the University of Toronto. He completed his bachelor's in psychology and master's of science in neuroscience at the University of British Columbia, and his medical training at Queen's University, and his psychiatry residency in the clinician scientist program at the University of Toronto. He recently completed a clinical research fellowship with joint training between the Addictions Division and the Temerity Center for Therapeutic Brain Intervention at CAMH, and was a NIDA-funded research in addiction medicine scholar through Yale University and Boston University. So lots of accolades. Dr. Victor Tang, welcome, and excited to hear what you have to share with us from your research today.
Thank you, Sarwar. And so I'll give everyone a moment to read through Dr. Tang's disclosures. And we'll note that all Teach Educational Rounds presenters are offered an honorarium, but a note that presentation content is not affected by acceptance of this honorarium. And also a note that the content of Teach Educational Rounds and Roberta Ferrence lecture are centered on evidence-based guidelines from the following sources on the screen. But these materials, as well as any verbal presentation or discussion, represent only general principles, and they do not remove the need for clinical assessment or treatment plans by healthcare professionals. And with that, I will pass it along to Dr. Tang to start his presentation.
Okay, well, hi everybody. It's a real pleasure to be here. Thanks so much, Rachel, Sarwar, Dr. Selby, and everyone that was involved in inviting and organizing this. I'm very happy to be here. Yeah, as mentioned, my main thing is that I'm a psychiatrist and I'm a scientist here at CAMH. I do research and clinical work in the space of addictions with a focus on tobacco and nicotine treatment for a lot of my research. And so I'm going to highlight these three learning objectives for my talk today, and it's as follows. The first is to describe the use of RTMS, and that's repetitive transcranial magnetic stimulation, which is a type of brain stimulation treatment that is going to be the biggest focus of my talk today. We're going to be trying to identify clinical factors, barriers, facilitators, knowledge gaps associated with RTMS, and then also start to describe different emerging neuromodulation modalities and their potential for treating nicotine dependence, other addictions, and kind of broadly the concept in the field of neuromodulation as it applies to clinical practice. And so I do hope that much of this research can demonstrate its translational potential. Okay, so I'm going to start off with kind of the basic background on tobacco use. And my focus on this is from the perspective of not only that many people still smoke, now more than ever, just by the body of people that are current cigarette smokers or use nicotine, but also people that are daily smokers who, by a lot of metrics, have nicotine dependence or tobacco use disorder, which of course becomes a public health concern, becomes a personal health concern, and can lead to all sorts of physical and psychological and other kind of interpersonal issues that characterize addiction. And so, that's the preamble that most of you are familiar with. And to orient you more, my talk is to focus on this idea of therapeutics and our need to kind of advance that. But, first of all, is just to mention that there are many smoking cessation approaches and treatments, many through kind of our healthcare systems that are evidence-based and supported by practice guidelines and policy recommendations. Something that for any general audience, I always start by saying, because, the concept of even treating people who smoke as kind of like a medical condition is sometimes not universally accepted. But within our healthcare provider community, like I mentioned, there are guidelines for how we can help people. And I just wanted to start off by highlighting kind of this recently published recommendation guideline published in the Canadian Medical Association Journal on kind of the best summary to date, especially since it was so recently published, on how we intervene for people with tobacco use disorder. And so this little infographic on the, I don't know if you can see my cursor, but this little infographic on the right side kind of shows the summary of everything in terms of what's recommended behaviorally, pharmacologically, and so on. But I highlighted the summary of recommendations for pharmacotherapy because kind of medical and biological treatments for smoking cessation is primarily my focus. And the first thing I wanted to highlight is kind of what's currently available is focused on a certain type of treatment, which is these types of medications that act on the nicotine receptor and are kind of nicotine receptor agonists in so many ways. And so unaided smoking cessation rates are as low as 5% if you use evidence-based treatments. It can go up to 20 to 30%, but obviously that leaves a lot to be desired. Even though a lot of our treatments have kind of this like smallish effect size, what's important to know is that quitting smoking can add so much years of life as well as kind of quality of life years, that any intervention that increases quitting even by a little bit can have big health effects, just because the kind of cascade of health benefits you can have over a long time span. And so research into addictions treatment has been primarily focused on neurotransmitter receptors implicated in the substance's mechanism of action, i.e. nicotine. And so how can we act on nicotine and that nicotine receptor? And that strategy has been, limited. And so I think when most people think about addictions medications, they think about this concept of agonist or replacement therapies. So nicotine replacement with the patch or the gum or varenicline or cytosine, they're all kind of they're like replacing what the person is using as a drug in the cigarette, which is nicotine. And similar analogies in other areas of addiction, such as with opioids, where you're using things like methadone or buprenorphine. And you kind of have this kind of like dose response kind of correlation with acting on that receptor to alleviate withdrawal and craving. But beyond just that kind of neurotransmitter and receptor model, evidence has advanced in recent decades to show that addiction can be thought of as a disease of the brain. And brain disease usually refers to, in a more simple sense, just that there are neurobiological predisposing factors like family history, and then also neurobiological changes as a result of chronic drug use or repetitively using this psychoactive drug. And so, the brain disease model of addiction is a particular term that can invoke all these other kinds of thoughts about, whether this interferes with a holistic thinking of substance use. But, I do like to distill it into this idea that they're predisposing factors and changing factors that is just as part of an overall understanding of a person, but nonetheless extremely helpful, especially in a healthcare context. And it parallels other chronic diseases as defined by the medical model, such as diabetes or hypertension. And one of the best commentaries that I've ever found on this is, a few years old now, by Dr. Volkov and George Koob of NIH, which basically kind of highlights that, at any point that you talk about the brain basis of an addiction, you also should kind of check or could check the fact that, it is also controversial, and it can invoke certain responses in people that need to be kind of at least put on the table in order to kind of acknowledge all perspectives and move forward. But nonetheless, these neurobiological models are very well validated in their own right. And, currently, one of the best ways of thinking about addiction is not a certain receptor or a certain region of the brain, but in distributed circuits, so that it's kind of like a concert of like interconnected networks that have certain functions. And so one of the best summarized models is this kind of 3-stage model of addiction that looks at binge and intoxication of a drug, followed by, if you don't take the drug, negative affect and withdrawal. And then in the chronic phase, this kind of preoccupation and anticipation of wanting to take the drug. And you can see that these kind of general kind of presentations or stages of addiction can be kind of mapped onto these certain circuits in the brain. And not just one region, but within these circuits. And so to kind of zoom in on this a little bit more, it's talking about incentive salience, which is a function of the brain that talks about what's important in your environment. Reward deficit and stress surfeit, which is basically functions of the brain that ramp up stress when you don't have something that you need. And then, executive function deficits, which is like this kind of cognitive or thinking brain issue with a bias towards rumination and craving. And so these are on certain circuits of the brain, such as for binge and intoxication, the reward circuit, which some of you may have heard about, that implicates dopamine. And for the negative affect and withdrawal, when people feel terrible without the drug, that's talking about an activation of circuits in the brain that are involved in a loss of reward and a highlighting of stress and aversive responses to things, such as like the amygdala and the bed nucleus of the stria terminalis. And then for the rumination and the preoccupation anticipation stage, that's mostly in the frontal circuits, which is kind of like in this thinking brain, frontal circuits that are involved in decision making, rumination, and introspection. And so again, the idea is to highlight functions of the brain that get hijacked by addiction, and that they are represented in certain circuits in the brain. And of course, there's ways to simplify the model, and then there's ways to complicate the model, right? So you have this 3-stage model of addiction that can also have this overlaying other stage that we refer to as interoception, and can include functions of flexible and goal-directed behavior, such as the insula or the anterior cingulate cortex, that is involved in sensing and integrating internal states and external states. So we all have all sorts of inputs, right? We got internal inputs, we're hungry, our heart's beating fast, and then external inputs, such as we're feeling hot, cold, stress, things like that. And the integration of that can be thought of its own kind of phase and circuit as well. So why is this interesting and have clinical relevance? I mean, many of you are aware that there's these like brain scan and these like neurocircuit models of addiction, but what does that mean from a clinical therapeutic standpoint? I want to highlight, this is a great figure from a review article by my colleague Tang from the NIMH, which kind of highlights the fact that, we understand our disorders to be represented across like different scales, right? From genes to molecules to physiology to behavior and so on and so forth. And, this idea that our treatments intervene at certain kind of entry points. And so the things that we think about the most, such as medications, intervene at the level of molecules. Our counseling and behavioral interventions intervene at this level of behavior and self-report. But, historically what's been missing is kind of an intervention point at the circuit and physiology level, a little bit bigger than molecules, a little bit smaller than kind of like the macro behavioral scale. And that's where we believe neuromodulation or device-based neuromodulation fits into all of this, including things like RTMS, which I'm going to talk about now. And so one of the other ideas about device-based neuromodulation is that there's different machines, different devices, and different techniques for how we can intervene at the circuit level. And so this is kind of like an overview of like different types of brain stimulation modalities. We're not going to get into all the details for this little bit of a busy slide, but this is one way to conceptualize it, just to have a bird's eye view of seeing like, oh, there's all sorts of different gadgets that can intervene at the circuit level. And one way to organize it is in levels of invasiveness, right? So invasiveness means that you can have something like electroconvulsive therapy or electroshock therapy, which is, relatively invasive in terms of side effects and being procedural, Some things that are completely surgical, you're using neurosurgery to implant electrodes in the brain. And then things that are a little bit less invasive, such as TMS. And this other scale that we can think of is also spatial resolution, which is that when you're stimulating a circuit, how focal or how precise is it? Right? So some things can be very, very precise. You're just stimulating this tiny bundle of neurons, and something can be like not kind of precise at all, like ECT just like shocks the entire brain. And so this is like a couple of organizing principles as you start to get familiar with this kind of like field, for the uninitiated anyway. A word about the field of neuromodulation and terms and subspecialties. So, I talk about neuromodulation, and then I use this word brain stimulation, and then I use like this word intervention. What do I mean by that? Well, neuromodulation just talks about influencing brain or neuronal activity through the targeted delivery of a physical stimulus. And so as this picture kind of shows, you got a brain and you just got different ways to kind of influence that neuronal activity. And the goal is to modulate activity by changing the function of these synapses, changing the function of these like brain signals. And it's thought to be in a lot of ways reversible as well. Brain stimulation is when the specific stimulus is a magnetic or electrical stimulation. So you can neuromodulate through a lot of different ways. You can neuromodulate through, a chemical intervention or through neurofeedback or things like that. But brain stimulation is specifically using electromagnetic stimulation usually. And this word of interventional usually talks about intervening at something at the level of something that's procedural. And so many of you in kind of like the medical field know that there are interventional techniques across medicine, right? You got your medicines and your behavioral interventions, but there's interventional things like, catheters and procedures and minor surgeries and things like that, which we think to be a little bit more interventional. And so hopefully that kind of clarifies a bit of that nomenclature and kind of like a broad strokes of the field here. And yes, we will be sharing a copy of these slides later. Okay, so RTMS is a non-invasive, it's a type of brain stimulation that specifically uses an electromagnetic coil to induce an electric field in the brain. And so basically what you have is a coil that has these rapidly alternating currents that create a magnetic field. When you put it close by or adjacent to tissue that is conductive, then that tissue can also have an induced electric field. And so brain is conductive tissue. And so if you put it near the scalp, you can create an electric field in the neurons below it and lead to kind of what we call neuronal depolarization, or basically activation of these neuronal cells. And then when you place the coil to stimulate a certain node or a region of the brain, there's this idea of focality, like you're applying focus stimulation at that site of the brain, but also there could be an effect on distributed circuits because, all regions of the brain are more or less interconnected in some direct or indirect way. And so you have this tool, and then you also have kind of the way that it's been translated to clinical practice over decades. And so current clinical use of RTMS in the mental health field is most commonly in major depressive disorder and in clinical depression, but there's also regulatory approvals for depression with anxiety, obsessive compulsive disorder, and most recently smoking cessation. And there's all sorts of research for how we can stimulate the brain so that we can also improve negative symptoms in schizophrenia, trauma symptoms in PTSD, and bipolar depression. And so when it comes to specifically in substance use disorders or addictions, the first overview that I think could be helpful is looking at these reviews and systematic reviews and meta-analyses, one of which we published at the end of 2023 that was finding, first of all, this body of literature is now pretty big. There's quite a lot of randomized controlled trials done in this space. And we looked across brain stimulation modalities, but within RTMS, there were the most. There are 51 controlled trials of RTMS across addictions. And of all of these substances, alcohol and tobacco use disorder was the most commonly studied. And because there were so many of these studies, we were able to do a meta-analysis, which is kind of like statistically combining studies to see an overall effect. And what we were able to find is that there were significant reductions in both craving and consumption for multiple RTMS treatment sessions in people with alcohol addiction, and a reduction in cigarette consumption in people with tobacco use disorder. And so this is a broad overview of the research literature to show that, like, yes, basically RTMS is effective for reducing cigarettes in people that are dependent. And so typically how these studies can be conceptualized is that you can measure something like craving or consumption before RTMS, and then give the stimulation and then evaluate the scores afterwards. And you provide repetitive pulses at the brain, which is why we call it RTMS, to induce changes in the brain. And so what you get in stereotypical study of this is, after one session, if you compare it to like a sham or like a dummy stimulation, you get a decrease in this craving that if you keep doing it for multiple days in a row, you get ongoing benefits, and the biggest clinical benefit after multiple treatments. And so what we're trying to do when we think about targeting and where to place the coil is these neurocircuit models of addiction. And so many of you may be familiar with this kind of basic idea of addiction where, on one side, you kind of have weakened cognitive control processes. You just have weaker brakes in terms of being able to hold yourself back from using substances. And then on the flip side, you kind of have too much on the gas for automatic reactions to substance-related cues. This kind of like drive towards drug-related cues is in overdrive. So too weak of one circuit potentially, too strong of another circuit potentially. And if you can map that onto certain regions of the brain and then have kind of like a hypothesis-driven approach to which circuit you want to stimulate, then you can potentially stimulate to help the overall addiction. So if you have like this kind of, perhaps you can do stimulation on this cognitive control circuit, which is blue. So you want to increase this activity, whereas the red, you want to use RTMS to decrease that activity, and it would be a different site and different parameters. And so this is kind of like the basic approach and the basic theory behind all of this stuff. And again, another overview of kind of ways we can do this is to kind of change the coils that we use for RTMS. And so when we say RTMS is useful for this or useful for that, there is some detail to it, right? Like RTMS can be configured in these different types of coils. So this is computational head modeling. So this is like a kind of a computer's view of you. This is like your brain, and then these are the coils on top of it. So this is like a metal winding of a coil, right? And depending on this, the way the coils are wound and positioned, you have this kind of activity of the stimulation activity in the brain, or the electric field that it induces, right? So if you have the coil looking like this, you have like a bit more of a widespread, that's red, stimulation here. It might be a little bit focal into this like tiny little point if you have this kind of like figure of 8 conformation. And so all of this to say is that there's like this incredible versatility to the way that you can structure RTMS coils in order to change how the brain is being stimulated. And then what's even more interesting is if you not only look at the different brain regions, but map them onto our models of addiction. So going back to how you can have different circuits underlie during different like kind of phases of addiction. So you kind of got these like kind of blue brain regions that are involved in binge and intoxication. You got these like brown kind of regions that's involved in the negative affect things. So then you can kind of like try to tailor your stimulation to those regions. And then, although it hopes to treat the overall addictive process, it's probably more focused on certain types of symptoms related to that circuit. And so this is a great review paper that shows all of the different research studies investigating all the different regions of the brain. So there are kind of like these many studies done on the DLPFC, these many studies done on the right occipital lobe, and so on and so forth. So, I mean, to cut to the chase, one of the most exciting things for the field was this FDA clearance for RTMS in smoking addiction. And so, like I mentioned, we studied RTMS for many years and many different types of brain disorders, but this is kind of like the first time that the evidence has reached kind of like FDA and then Health Canada, like regulatory approval for the use of one of these devices. And so, it kind of like broke the glass ceiling, so to speak, that like, this could be a Health Canada approved frontline treatment for people with smoking cessation. And it was very exciting. But like I mentioned, we're talking about a certain type of brain stimulation, or RTMS, which is this deep TMS coil that looks like this, and by this manufacturer called BrainsWay. And so what supported this was this pivotal multi-site randomized controlled trial looking at 262 smokers and found that compared to the 20% that was able to quit with active sham, it was much greater than the 8.7% in the sham condition, showing like a great separation from placebo. And so the two main studies that I'd quickly highlight is that pivotal trial with this many subjects that showed this continuous quit rate between active and sham at both week 6 and week 18 of follow-up. But also this is supported by another foundational study, which was this relatively large pilot trial that was done in 2014 that looked at RTMS versus sham, but also looked at high frequency RTMS and low frequency RTMS. And what you'll see, at least in this first figure, in terms of like people that were able to achieve 50% cigarette reduction, that the greatest effects was in this high frequency stimulation arm compared to low frequency or sham, and roughly equal in people that got this kind of like smoking cues or neutral cues prior to stimulation, which I'll talk about in a couple of slides. But these are kind of like the two big randomized controlled trials that like support our evidence base as well as the regulatory approvals. And so this is kind of like the main component of the treatment that was approved. It's this daily treatment once every single day for week 1, week 2, and then week 3. And then after that, you do once a week, 3 times, for a total of 18 treatments. And then they did a bit of this follow-up period. Zooming in on each one of those dots, so each one of those individual treatments, you have someone sitting in a chair and first being exposed to smoking cues, like cigarette cues through pictures and images. So it's activating like craving first before delivering this stimulation. And then after that stimulation, there's like a brief counseling session. And so that's kind of like the package on a daily basis. And then there's this like full course of treatment with like multiple treatments overall. And we recently summarized all of the clinical aspects of this trial in this practice innovations paper in the CMAJ that you can look at for interested clinicians. And yeah, so what is deep TMS? So again, I keep alluding to different coils and different ways to stimulate the brain. And so what these studies did was use a specific type of coil that stimulates deeper than quote unquote conventional figure of 8 coils. And so this is the coil that was approved. And this is like the electrical field model that kind of shows where in the brain is being stimulated. And you can see with the deep TMS coil, you're stimulating more areas of the brain than other coils. And you're stimulating, or what they're trying to do is stimulate, most importantly, the frontal cortex, which is part of this area of the addictive model, as well as the insula. And so it's targeting both the preoccupation and anticipation kind of functions of addiction, as well as the interoception functions of the neurocircuit model. And that is what is thought to be the mechanism that's driving this benefit for people to quit smoking. So let's get a little bit into the details, right? So you have RTMS, then you have these trials that basically showed that at least this type of RTMS is very effective for at least this type of addiction, tobacco or cigarette smoking cessation. But obviously, as clinicians and people in the healthcare sphere, there's all sorts of other details that we need to think about in order to really bring this to patients, right? So the first thing to think about is, so who is this treatment good for, right? There's all sorts of different types of smokers. They're all different. And so this is a follow-up study, a secondary analysis that we did in the Intrepid lab, trying to create a predictive model, looking at these different kind of clinical predictors or clinical subtypes of, of people with tobacco use disorder, and seeing which one predicts smoking cessation, like people, what factors predict quit in that pivotal trial that I talked to you about. So we took that data set, we ran these models, and well, ultimately we couldn't find anything clinically significant or statistically significant to show that it affected the model or could predict quit out of that data set. But we did show that there was a suggestion that perhaps treatment effects were larger amongst younger people and those that have higher levels of incentive salience for tobacco cues prior to smoking. And this provides a bit of a clue about where we can look for future research in terms of like who specifically might respond to RTMS. And typically in these kind of predictor analyses, you do need larger samples. That we were probably, the sample that we probably had was too small for that. Okay, and then here's this follow-up study. This is an interesting and provocative title to a research paper. It's does deep TMS really work for smoking cessation? And so this is a follow-up study that was published, I think, 2 years ago, which basically it was one of the sites of the pivotal trial that actually was supposed to be part of the pivotal trial, but got left out due to institutional delays. And a few years later, after federal approval, they published their results, and they actually showed that they didn't have a difference between active and sham stimulation. So at least in this site in Brazil, they didn't find a benefit over placebo. And so this feeds into a little bit of our thoughts of the original trial results, which is that the findings may be modest at best and doesn't work for everyone. Could combining with medications work, right? So we know that within routine clinical practice, we're already prescribing things like NRT or varenicline. And so this was a trial that was done with a group of CAMH that combined deep RTMS with varenicline, which is probably the best medication so far for smoking cessation. And so in this study, everybody got varenicline, but half the people got deep TMS on top or sham TMS on top. And this randomized controlled trial showed that at the primary endpoint, at 3-month follow-up, there was a significant increase in quitting for people that got active RTMS. So what was exciting about this result was that, in people that got this evidence-based treatment, varenicline or Champix, if you added RTMS to it, you get even better quit rates, which unfortunately didn't hold up in the follow-up phase at week 26, but shows that at least in the short-term phase, a combination approach can be more effective. There were no differences in a lot of the secondary outcomes, but fortunately or luckily, there was a difference in the primary outcome. Some of these slides I'm going to have to gloss over in the interest of time, but happy to go over them later. Okay, so what about this craving business that I mentioned a bit earlier? So this is what happens at each session. You ask people for their cravings on this visual analog scale. So on a scale of 0 to 100, what's your craving? Then you do these smoking cues. After the smoking cues, you ask them again, okay, now what's your craving? Then you give them the stimulation, and then you ask them the craving again. That's VAS3. Right? And so these are the types of cue-induced craving protocols that they employed in these studies. And the idea, the theory behind it is to kind of activate this craving circuit, which that then RTMS can intervene with or modulate, right? So it's a little bit of this like 1-2 punch, activate and then stimulate. So, this is something that they did in the trial, and we had another question for the data set, which was, how important was this cue-induced craving protocol? So this is a secondary analysis that we did that is currently under review. And the first thing we showed was that this craving protocol does increase at least a small amount cravings in people. So, when we give people this kind of craving, we show them these pictures and things like that. Clinically speaking, we get a bit of skepticism, right? People are looking at these pictures and they're like, I don't know what this is doing to me. It's kind of boring. It's not really doing anything for me. But, the data set does show that we are able to, with those pictures, induce like a reliable increase in craving that is small but statistically significant, and also does not habituate over time. So you can keep showing these pictures over and over again, or these images, or the feeling of the cigarette, and it does produce like a reliable increase in cravings. But we also showed that there was no interaction between cue induction and treatment arm, such as the magnitude, like how much you could trigger someone's craving, was not associated with quit. So therefore, we showed that like stronger or weaker induction of craving doesn't actually correlate with the treatment effect, which actually shows that maybe it calls into question like this craving induction protocol at all. And we also furthermore showed that if you had higher cravings overall, you might have worse outcomes, which is confounded by a bit by just what we know generally about people with that smoke, which is that higher cravings usually predicts worse treatment outcomes. So what else can we do? Can we measure the brain while we're providing RTMS? And this is just like a quick plug for some ongoing research we're doing, which is that you can do what's called TMS EEG, and this is with my colleagues, Dr. Zrenner and Dr. Zrenner at CAMH, where we can actually measure people's brain activity with EEG while we're showing them craving cues. So we're currently running a study that's showing a smoking cue, and showing a distracting cue, then showing a smoking cue, and then showing a distracting cue, to kind of find the brain signals that are involved with the cravings and what might be associated with treatment. Because there is a potential that it's not just inducing the craving, but that there's like a specific brain state that you want to stimulate only in. And so there's this idea of closed loop stimulation, which is that you're using brain signals to look for exactly the signature that you want to stimulate, and only stimulating at that time. So this is a bit of pilot data, which is probably a bit too cumbersome to go over right now, but that's a bit of work that we're doing here at CAMH. Okay, I'm going to talk a little bit about implementation and translation. So, you have this treatment that's evidence-based. There's some Health Canada approvals, but we are starting to highlight now in our lab kind of what are the implementation challenges to RTMS. You have this kind of fancy equipment with this fancy protocol, and then the question is, can this actually be delivered in clinical practice? We published a review article kind of highlighting these things, that there are accessibility challenges, education challenges, and real-world clinical considerations. And so there's all these implementation and design issues that we need to actually go to patients and providers about before it can actually be rolled out. And so, I point to this RTMS for MDD thing as an example. Right. So RTMS for depression has actually been around for such a long time. The first FDA approval for that was in 2008. And for all of you frontline mental health clinicians, you can tell me, how much do we see RTMS in frontline clinical practice, even though all of these approvals and research was done so long ago. And so it's this implementation gap that implementation scientists have talked to us about for a long time, which is that, we shouldn't underestimate how long it takes to translate things into practice. And so you can have these efficacy studies and hope that they improve public health, but probably what we need to do is also these real world effectiveness and implementation studies before you actually get through this pipeline to real public health impact. And so what do I mean by efficacy versus effectiveness study? Well, when you do these RCTs, you look at the treatment under ideal kind of research academic settings scenarios, whereas effectiveness studies tries to do these types of trials out in the real world in a pragmatic setting where the protocol is a little bit more flexible and the inclusion criteria is a little bit more flexible as well, much like we do in real world clinical practice. And so what I'm going to gloss over, but to highlight, is that, this is really important for us to understand in order to figure out what are the implementation barriers to bringing that public health benefit. And so we did a study here in the Intrepid lab where we provided an infographic, and we did kind of this mixed methods evaluation with both a survey as well as a qualitative interview in order to get patient and provider experiences. And so the first thing we found out about this, we did this large survey looking at people's knowledge and attitudes. We got about 150 people. And the first thing, I'm going to highlight a couple of the findings we have here and go over it again a bit quickly because of time. So, the first thing is, pointing to that education gap. It's definitely there, and a lot of people are not aware that RTMS exists or can be used for smoking cessation. But, when you tell people about it, just something through as simple as an infographic, patients are actually quite happy or at least interested and find that it's highly acceptable. What they hear about the safety risks and the duration of treatment and the time commitment and how appealing it is. And so this survey was very reassuring in showing that real world patients in our clinic or that go through the STOP program are interested in something like RTMS, and that people are willing to travel. They might struggle with affording transportation, which is something that we have to address. But the interest is definitely there. And healthcare providers, when they hear about RTMS too, when you try to address this knowledge gap, also find it highly acceptable as well. Although interestingly, maybe to a lesser degree than patients, in terms of, the majority thinking that this could be a good match for some of my patients, but not everyone, right? And so there is some reluctance, and definitely there needs to be some consideration about, the large chunk of people that this might not be a good match for. And then we did qualitative interviews. Some of the main motivators was dissatisfaction with available treatments. And so, for all of like the conundrums and uncertainties that we have with RTMS, it goes back to what I said on the first slide, which is that like people try things, it doesn't work, it, has a lot of side effects, and, we just need more options, right? And they highlighted these things that, facilitators would be as if things are highly accessible or flexible, but barriers if things are rigid and the time commitment is too much. And similarly with healthcare providers, this idea that, RTMS seems to be effective and could be effective, but maybe not for everybody. Now that I hear about it, it's not something that I've really offered everybody. I haven't really been discussing it as part of my here is every eligible treatment option at this time. And I think we do this in clinical practice anyways. We don't run the laundry list every time. We do try to tailor things. But it's probably more helpful, at least from the healthcare provider view, that it would be a second or third line option. And that these oops, I think I froze.
You're good now.
But
Don't worry.
yeah, I think I'm back. All right. And that, it's important to build partnerships with community clinics, have clear referral pathways, and to address the lack of knowledge amongst general practitioners. And so another thing to think about is scheduling. And this is the kind of once daily schedule of RTMS that most RTMS protocols are doing. But a lot of research is being done now in these kinds of accelerated protocols. And so this is an example of accelerated protocol of RTMS for depression, where, as you can see in this like orange bar, you're only coming for treatment for 5 days. But in these 5 days, you're actually getting, I believe it's 10 treatments a day or 8 treatments a day. And so this is a way to condense things that makes the course shorter overall and could be an attractive option to some patients. And then what's even less tested is this idea of a flexible schedule. Can we offer treatments specifically on days that patients are available to attend, or even so much less, like once a week? And so this is something that patients consistently brought up. There's a bit of research on it, but there's more that needs to be talked about. So cigarette smoking is very common in people with mental illness. What we're seeing now with the arc of history is that, smoking may be decreasing overall, but it remains high in people that are marginalized and have mental illness. And so this is important because many psychiatric disorders are less likely to respond to conventional treatments, such as varenicline or nicotine replacement therapy. So for example, in the Eagles trial, 38% were able to quit from varenicline, but only 29% in people that had a comorbid like psychiatric condition. And so smoking cessation trials have historically excluded individuals with mental illness, which is something that we need to look at when it comes to RTMS. And so, yeah, I think that's one of the questions in the chat about whether it works with people with concurrent disorders. It's something that we quite frankly don't know, and we need to study more. I actually don't have a slide on contraindications and side effects. So the main side effect is headache and dizziness. That's common. Maybe like 30 to 40% of people will get headache, or what we call scalp discomfort. But for the most part, that doesn't lead to dropout. And so in many studies, they're not considered as severe adverse events. And the most feared complication is seizures, but the prevalence of that is probably less than 1% per treatment session, maybe to the order of like 0.0001% chance of getting a seizure. And more so if you have other risk factors like epilepsy. So is epilepsy a contraindication? For most people, yes. But you'd be interested to find case reports and some studies of using RTMS to treat epilepsy, or even to treat things like migraine. And so there's all of these kind of like paradoxes that I won't get into today. But the bottom line is there is usually no absolute contraindication unless that specific center delineates it as so. So this is to highlight a current hybrid effectiveness implementation trial specifically for people with mental illness that we're running here at CAMH. And so for people that are interested, if you refer to our lab or to the nicotine dependence clinic at CAMH, they could be considered for this clinical trial if they have mental illness. And I have a bit on cannabis use disorder, but I'm going to skip over that and talk a little bit about the broader frame of other neuromodulation modalities. So the first thing, I want to go back to this point of there being different brain stimulation techniques. And so one of the first things people ask us when we talk about RTMS, and they've never heard it before, is it electroshock therapy? And no, it is not. And for people who are aware, electroshock therapy has been around for a long time. It's probably like the OG brain stimulation technique, right? It's a little bit less focal, but it is using electrical stimulation to stimulate the brain. And the difference is that you require anesthesia, you require usually a recovery room, and it stimulates the entire brain. You can see kind of like red, intense stimulation across the entire brain, whereas RTMS is a little bit more of like an office-based procedure. It looks like this, and it's a focal stimulation within the brain. Okay, but the other point to highlight again is that the goal of all of this stuff is to think of them as tools, right? And it's like any other clinical tool. You want to match the tool to the target, and every tool has slight advantages and disadvantages. And there are different modalities that we should be aware of, not necessarily be tethered to one of them, but to see how it can affect or target like our theories and our models of addiction to help our patients. One of them that I would like to highlight is transcranial direct current stimulation, which is another line of research that's being led by my colleague, Dr. Zevertello, who's a scientist at CAMH. And they are currently running a trial using TDCS, or transcranial direct current stimulation, as an adjunct to varenicline. And this is a randomized controlled trial that they published a successful pilot on and is currently doing a larger RCT. TDC, and so the idea is to combine this like super effective medication, but also to the region of the brain, the dorsolateral prefrontal cortex, that's involved in addiction, and see if there can be a synergistic neuroplastic effect from brain areas involved in addiction. And so, the pilot study was very successful. People had a greater quit rate in those that had active TDCS versus sham. A quick kind of like picture or a word about TDCS is that it's a type of modality that has weak stimulation over the brain. Oh, I guess I don't have the stimulation, but it kind of looks like this. It provides a weak electrical stimulation over the brain. And what's exciting about it is it's a little bit less cumbersome in terms of the equipment. It's portable. Or could be portable and could be adapted to an at-home device, which is something that Dr. Zevertello is doing in this follow-up RCT, using an at-home version of this TDCS device. So the future of neuromodulation as a field, there are kind of lots of grumblings within the field to create like subspecialties of interventional psychiatry or subspecialties in brain stimulation. we provide in the Department of Psychiatry a lot of continuing medical education and even fellowship opportunities in brain stimulation and interventional brain stimulation that people can check out. And, it's becoming so common that like many hospitals, not just academic hospitals, but even community sites and distributed sites have their own interventional psychiatry divisions or brain stimulation clinics that offer brain stimulation as like a treatment modality in general. And as the addictions indications start to increase, it should probably be part of mainstream practice as well. So yeah, RTMS is an evidence-based and efficacious and safe approach. We are trying to figure out all the different factors that affect its efficacy and eventual implementation. There's a growing field within addictions that can be spread across many different neuromodulation modalities. They all have similarities, they all have differences, they all have advantages and disadvantages. And I hope I've kind of triggered some interest in you guys that are not familiar with the field in terms of kind of this new frontier of treating nicotine dependence. So that's kind of my whirlwind topic. Sorry for running a little bit late, but I'd want to thank all my collaborators, especially those at the Intrepid Lab, Dr. Selby, Dr. Zabertello, and my trainees and the funding support. And I think I have a few questions to answer questions and happy to stay late as well. Thanks so much.
Thank you, Dr. Tang. That was very interesting, very engaging. So I appreciate you taking the time to share that all today. I know you were able to get to some of the questions, but I'll just see if maybe we can take one more. Were you able to answer if it would be only for smoking or if it could be applied to nicotine vaping as well?
Yeah, it's only in tobacco right now. I mean, theoretically, it should be the same, but we don't know, at least through the studies. Dr. Zabertello is doing a TDCS study just in vapors, so that would be of interest. And we're hoping to expand that frontier as well.
Thank you. And there was another one saying, does RTMS help to stay being a non-smoker for a long time after 18 sessions, or sessions need to be given once or twice a year for the next 5 years or so?
Yeah, the current RTMS studies that are done on it, which is very few, show that it isn't super long lasting. So it lasts definitely in the acute period. People can stay quit even up to 18 weeks, at least compared to sham. But beyond that, it's uncertain. There haven't been any studies in maintenance protocols, but in the RTMS for depression world, there are some very effective protocols of giving once weekly or once monthly treatments. And some clinics of RTMS for depression can give like maintenance treatments, which is usually, again, once a week or once a month if people want to keep up with the treatment.
Thank you. I'm just seeing in the chat, everyone is saying thank you and found it just as engaging as I did. I think we have time for one more. Dr. Tang's email is on the screen if anyone has any questions, but there was one that said, you mentioned it wasn't approved by Health Canada yet. Can you say more on this?
It is approved by Health Canada. So that DPMS coil for smoking cessation that I said was very exciting that FDA cleared it. Health Canada also cleared it. So they cleared it specifically for that DPMS coil for smoking cessation.
Thank you. So yeah, okay, again, if anyone has any questions, feel free to reach out. I'll also include, I can include contact info if anyone was interested in signing up for that study, and I'll send it out at the end along with the evaluation for today. But for now, if anyone needs to go at this point, completely, it's okay. I'm just gonna wrap up a few other slides, but thank you again. So just a reminder that the eval and post-learning assessment will be sent by end of day tomorrow, and you'll have a week to complete that, so next Thursday. And we have another talk coming up next month, and it will be on the intersections of health equity in cessation, 2S LGBTQ+, cannabis, smoking, and vaping with Dr. Michael Jane, and that's on October 15th. So stay tuned, you'll see registration opening for that as well soon. And if you missed a portion of today's webinar or would like to view it again, we do have an archive on our website. And we will be sending out slides just to address that, as Dr. Tang said. We'll be sending it out to everyone. But for now, thank you so much. I hope everyone enjoys the rest of their day. Thank you, Dr. Tang, too.
Yeah, thank you, everyone. Thanks for your attention. And yeah, please email me. I'd be happy to talk about any of you about this further.
Thank you.
Thanks.
Bye, everyone.
Bye now. See ya.